Dr. Sanjay Prasad is on a mission to improve surgical outcomes. After many years as a surgeon, he founded a company that helps patients find the best surgeon for their condition and to avoid surgeries that they don't need. He's also laser focused on reducing racial disparities in surgical care. And he's written a handbook for patients, resetting healthcare post-COVID-19 pandemic. In this episode of the HealthBiz podcast, Dr. Prasad describes his immigrant roots, what made him decide to become a doctor, and how he developed insights about what's wrong with surgery and how to fix it. I'm David Williams, host of the HealthBiz podcast and president of Health Business Group, a strategy consulting firm that helps healthcare and life sciences companies develop robust growth plans. Reach out to me at dwilliams@healthbusinessgroup.com if you'd like to discuss strategy for your company. And finally, do me a favor and subscribe to the podcast. Well, Dr. Sanjay Prasad, welcome to the Health Biz podcast. How are you today?
Oh, thank you, David. Thanks for having me aboard. I'm happy to talk to you and very excited about this podcast. Thank you.
Oh, that sounds good. Well, we're going to talk about surgery, but before we get into that topic, I'm just going to ask about your background a little bit and tell me about your background. What was your childhood like? How was your upbringing? Any particular childhood influences that affected you overall, or got you to decide to go into medicine?
Yeah, David, I was born in India, and I was a year old when I came to this country, to the Washington, D.C. area, 1962. You'll know how old I am now.
Uh-oh.
But yeah, we came on a month-long journey through the Suez Canal by ship, because that was the mode of transport back then. And really, my mom was telling me this just a couple weeks ago. We came here looking for a solution to a healthcare problem in the family. We were looking for an orthopedic surgeon, and it's so astonishing. And I don't know, maybe it's fate. I don't know what it is, but I grew up in the Washington D.C. area. I became a surgeon. Um, I decided I wanted to go to surgery in 7th grade when I went to visit my ear, nose, and throat doctor, and he took care of my ear infection, and he was a real role model for me. And sure enough, I became a surgeon and started doing ENT as well as neurosurgery, and that combination, neurotology. Did that for about 30 years, helped tens of thousands of patients. And now I want to help patients get to the best-in-class surgeon for their condition and avoid unnecessary surgery. So that's what the whole idea is.
No, it sounds pretty good. It's good if you can get a role model early on that is, an excellent role model surgeon as opposed to, like, say, a drug dealer or somebody like that. So I'm glad that your mom took you to the right place. So it's a good,
Yeah, yeah.
good career to go into. Now, in terms of, surgery, and as you're saying, dealing with tens of thousands of patients along the way, any observations that you made as part of that were, not just related to your individual patient, but what you'd seen in terms of the patient journey and, different issues with that?
Well, I mean, the first thing was cost. And so what I did in 2007, I started a surgery center, started bundling some of the costs involved with, outpatient surgeries. And that means we were putting together the surgeon fee, anesthesia fee, facility fee, low cost. 2007, 2008, the big bubble. A lot of people had no insurance. Some had high deductible health plans. They still couldn't get their surgery because they had to come out of pocket. So it was very attractive. It really attracted a lot of patients to that formula. It was a great solution. But the piece that was missing was really the quality and the surgeon outcomes. Doctor, how many have you done? What's your success rate? What's your complication rate? And how are we going to connect patients to best-in-class surgeons? That's the piece that was missing. And that's why we started the company, Surgery Quality, in 2014. And it's a solution for this.
One of the things that was notable, I remember, those of us in healthcare know that you want to see things like what's the volume of surgeries that somebody does, who do you go to? But even you think some, well-known people that should have had, access to the best. I'm thinking about the former President Clinton. I think it was analyzed that, where he went for surgery wasn't necessarily the place that an informed consumer would go. And it's just nothing to pick on him particularly, except to say, it wasn't easy, even now, but it wasn't easy to figure out what you should do if you need surgery, who you should go to, and so on. What is the typical process where somebody gets into surgery? Leaving aside your company for a minute, which we'll talk more about shortly, but what's the normal process? Like what happens in terms of somebody realizes they have an issue? How do they get from that realization, to going under the knife, so to speak?
So, you develop a tummy ache or a lump on your thyroid, or, or your shoulders aching all of a sudden, or a swollen joint, or a headache, or whatever it might be. You can't quite see right. First thing, you go see your primary care doctor, which is all nice and fine. They may do some tests, but they ultimately end up usually referring you to a surgeon, a specialist. And this is where the heart of the problem is, because primary care physicians, they want to do what's best for you, no question. I'm not denying that, but oftentimes they just have a list of surgeons in every specialty that they normally refer to. Maybe these are golfing buddies. Maybe their kids went to the same school. Maybe they're in a medical office building and the gastroenterologist is upstairs. It's so easy to send the patient right up. Um, but what's happening is these referrals, David, are happening not on the basis of costs. Is the surgeon in network? Is there endoscopy suite or their hospital in network? Is the anesthesiologist in network? And also not made on the basis of outcomes. That is, how many the doctor's done, what his success rate is, what his complication rate is he up to speed with the latest technologies? These are all very important. So what's happening as a result is that patients are getting surgery that they don't need. And depending on specialty, 15 to 30% of surgeries that are being performed today are unnecessary. And patients are suffering from complications from these unnecessary surgeries. Patients are getting connected to surgeons that don't necessarily have the best outcomes, needing revision surgery for wrong implant size or infection or scar tissue. It's a vicious cycle. So, the system is begging for a solution, no question.
Now, you had written a book, Resetting Healthcare, and I'm wondering, what's the main concept behind that? I'm assuming some of these same philosophies we're talking about, but what was the concept there, and what kind of reception has the book received?
Yeah, I mean, the book is called Resetting Healthcare Post COVID-19 Pandemic. It's written for the patient, so it's called the Patient Handbook. And I wrote this when COVID happened, surgeries were on pause in 2020. And, the COVID pandemic did so many different things to healthcare, as we all know. It paused surgery scheduling in 2020, and in 21 and beyond. Patients are still somewhat apprehensive to go into a hospital, fearful of getting that Delta virus, Delta variant, if you will. There's still some fear there, but it's a great time to reset healthcare as we know it today. From that, and what we're talking about is reforming, optimizing that referral process, which is so critical.
You mentioned certainly the big shock of surgeries, just the big shock of the pandemic and what happened to surgeries and other things once the pandemic began. You mentioned 15 to 30% of the surgeries are unnecessary. Well, for sure, all those stopped, but then you had all the necessary ones as well. When we look, sort of broadly at what happens once the pandemic recedes or ends, whatever it may do you think that there's a likelihood that things will just sort of go back to where they were? I mean, I know the idea is sort of like to reset it, maybe start at a new point, but are the forces sort of driving things back to normal, and or I won't say normal, but how they were before, or do you see real hope for this kind of reset?
Well, I don't think healthcare is ever going to be the same, ever, because we had an explosion of telehealth, telemedicine, which was really sorely needed, but just it wasn't happening prior to the pandemic. And telemedicine was so critical for patients, to survive talking to their healthcare provider during the pandemic, and that has persisted to the point where every practitioner now has an ability to have a virtual visit with their patient. This has been a great, great advent. And I think this is going to continue and be fostered, no question. And with wearables and adding more data and getting the data to the surgeons and their practitioners, look, digital medicine is taking off in a very, very big way. as a result of the pandemic and the changes that have happened. So the changes will continue. There's no question. The
Yeah.
system will continue to evolve.
One of the things that's happened is there clearly the televisits, telehealth went up to 80 or 90% of visits at one point. Now it's kind of reset at a much higher level than it was before the pandemic, but down to like
Mhm.
20% of visits from had been 2% before the pandemic, now 20%. Um, and I guess one question is when you give people the definition of what a telehealth visit is, then in general, unless they're looking way into the future, they usually say, well, that's surgery would be the last thing that you could do with that. Now, obviously, not every visit with a surgeon, the surgeon's office needs to be in person, but how does telehealth fit into a surgery practice?
Well, telehealth does fit in when you're talking about post-operative care, for no question. The initial diagnosis, listen, you can look at medical records, you can look at imaging, and you can make determinations, validate necessity. There are all sorts of avenues to construct. And, our platform is really three things. It's one that's concierge platform that handholds the patient. And when you're told you need surgery, we can get a HIPAA release from you. You sign a form. We source your medical records and your imaging. We send it up to the cloud, and then we send it to multiple surgeons, all within your Blue Cross network. And we ask the surgeons to validate necessity, put in their past outcomes. We corroborate their past outcomes, and then you get to pick your surgeon who's already seen your records, and you're able to compare them according to success measures and complication measures. It just makes a ton of sense. It puts the patients back, David, in the driver's seat,
Yeah.
as opposed to entering the healthcare system and then kind of being, kind of nudged in one direction or another. All of a sudden, you take control. You take control of your body. You take better care of your condition that you have, and you have total control with which surgeon to see, what type of approach to have, what the outcomes are going to be. It lessens your anxiety, and if you have panic disorders, it settles those down. There's just so much that's positive with this.
Yeah. Now, Sanjay, what happens in thinking about like different situations for patient? Now, clearly, there's the so-called elective procedures where you have enough time to do the planning, and I can see how that could work very well. How much of the surgery sort of fits into that category versus something that's happening really fast and the patient doesn't have the time to even understand this is available to them, or they just feel they just have to get things done right away, or they're just under so much pressure or pain that they need to do something. And I'm sure there's some, on both ends of the spectrum and some in the middle, but how do you think about those?
I mean, look, there's some surgeries that are just urgent, right?
Yeah.
I mean, you've got bleeding, or you've got a perforated bowel, or a joint that just needs attention because you've got a fracture that's just got to get done. Those are not applicable to this platform. But 92% of all surgeries are non-urgent. And when I was researching my book, that's what I realized. So 92% of surgeries can wait for an evaluation, uh, a medical record distribution platform at the speed of electrons with data coming back to you within 24, 48 hours. You can certainly wait in most cases.
Now, I understand how you get people to the, to the right surgeon, and with the right quality and so on. How do you deal with this issue about unnecessary surgeries? Is there ways that people say, gee, you think you need surgery, but maybe there's another approach? Is that part of your platform? Or is that something separate?
Yeah, I know, absolutely. It is part of our platform. So now, using the Surgery Quality platform, you as a patient can get peer reviewed. In other words, the case gets peer reviewed by a number of surgeons who validate that yes, indeed, you do need surgery. And there will there will be a few surgeons that will look at your case and say, hey, you know what? Maybe physical therapy is a little bit better. Initially, it may solve the problem. So now you start to have options other than surgery. It just makes so much sense.
Now, help me understand, where this is targeted in the market. You mentioned, I think the Blue Cross network is where people can be referred, but who is the buyer of your services, and who uses the platform?
So we're going to self-insured employers. We're going to large companies, Fortune 500 companies, captured audience, lots of lives. wanting to do better for their employees. And we also solve a problem that people don't talk about much, and is racial disparities in surgical outcomes. And I can tell you, about a year ago, I was researching this topic. I wrote a paper on unnecessary hysterectomy, and I was astonished to learn, David, that hysterectomy is performed in Black women at 4 times the rate of white women. And you can blame some of that to extent of disease, or comorbidities, or socioeconomic status, but fourfold increase is pretty astonishing. So I dug deeper, and I found an article in 2013 that from the group from Brigham and Women's, the Adel Hayter and his team. They did a meta-analysis, 88 articles, looked at racial disparities with Black and white patients, and they found the surgical outcomes were much poorer for Black patients across an array of surgeries. And the underlying theme is this: Black patients simply don't get referred to high quality, high volume surgeons. So that's where we are really definitely a solution for that.
It's very interesting to be able to go at the root cause in that way. Do you think that do you think that's also partly just how common the surgeries are is also because they're referred to people that are not discerning in terms of saying this surgery is actually not necessary, or is it also so I'm trying to understand the difference between kind of how common the surgery is versus also the outcome side of it, which is what you emphasized as well.
Well, the one aspect is reducing unnecessary surgeries, but the major aspect in terms of racial disparities is that they just can't get connected to the high outcome, a high volume, high quality surgeon. That's really been that's the solution that we have. And I can tell you that when you look at ovarian surgery, ovarian cancer surgery, liver transplants, kidney transplants, it's astonishing that Black patients just don't do as well, even when you control for socioeconomic class, extent of disease, comorbidities. Something's got to be done to elevate the health of Black America.
Did they do better? Did they do similarly when they are actually referred? In those cases, they are actually referred to the high quality surgeons. Does that
Well,
address it, or what remains after that?
that's David. That's certainly our hypothesis that they will do better. We haven't played that out yet, but we expect that they will. And I think the healthcare system, David, traps patients sometimes. And the example I usually give is a Spanish-speaking patient wants to see a Spanish-speaking primary care, wants to see a Spanish-speaking surgeon, but that surgeon may not necessarily be the best surgeon for them in their network. And patients, have this Blue Cross card or Cigna card or United Healthcare or Aetna. They have a huge network of surgeons to pick from, but they're really working with a micro network, if you will, a geographically micro, small network within that larger network that they pay for. So we're trying to, it just makes a ton of sense, right? To go to the best surgeon who's
Yeah.
done more shoulders than anybody else, who has the best results, and get the best outcomes.
Some larger, more sophisticated companies, I'm thinking like a company like Walmart, for example, has programs where they send people to well-known places like Mayo Clinic.
Mhm.
And is this a kind of how does a program like that fit in with what you're doing here? How would you compare and contrast it?
So large employers are sending their employees. They'll send, and I don't know if I'm just making these up, but I think they're sending knee replacements in certain academic institution, hip replacements in a certain place, heart cases to another institution for a fixed bundled cost, which is all nice and fine. But we are looking at procedure-specific metrics. We're looking at metrics that matter to patients when they need surgery. For example, when you're having gallbladder surgery, we're looking at bile duct injury rates. That is how many times a surgeon may have inadvertently transected an aberrant bile duct, for example. We're looking at measures that are very specific to their procedure, much more meaningful. Instead of trying to drive patients to bundled pricing solutions and academic institutions, let's make the patients more educated, learn more about their condition, So they own their own condition and they can make well-informed choices. It just makes a ton of sense to me.
Now, how well has the business been going? It sounds very persuasive when you discuss it, but how does it fit into like all the other things that an employer would look at? How are you doing distribution? How are things working out?
So for employers, they don't really have to change anything. They can use their current health plan because most other solutions, you have to change your plan.
Right.
It's very painful. The employees are not happy. But here, it's just a bolt on. So
Yeah.
you already have a Blue Cross plan, for example, but we're just an add on, a feature where, we're helping your employees get to the best surgeon. So it's really a pretty, it's pretty seamless.
Yeah. So you had this described before. You're sort of a micro network. It's sort of helping people to use the whole network that they have, and you're making
The
it
whole network. Yes,
easier to do that. Good. Well,
exactly.
it sounds interesting and useful, and I hope I never have a need for your services. But I know that typically speaking, people do end up with a surgery at one point or another. Or somebody will. So it sounds like a good approach. Let me just end by asking you about any books. We talked about books that you're writing. Any books that you're reading that you recommend?
Well, I'm reading. I'm a big tennis nut. If
Yeah.
anybody who knows me in my area, I'm just crazy about tennis. I'm a big Roger Federer fan, and I'm reading his new book on the Master. It's really enlightening. Uh, he has a lot of talent, but people sometimes forget the hard work and the
Yeah.
persistence and the discipline that it requires. A lot of people saying, no, you can't do it,
Yeah.
and then doing it, and it just overjoyous. And, he talks about that in his book. And, it translates, right? It's not just tennis, not just a sport. It translates into so many things in life. And it's all about being passionate about something in your life, wanting to leave something behind before it's all said and done, leaving a better healthcare system for the next generation. That's where I'm all about.
That sounds good. Well, Dr. Sanjay Prasad, thanks very much for being on the HealthBiz podcast today and telling it like it is and like it should be in surgery.
Yeah. Thank you so much, David.
You've been listening to the HealthBiz podcast with me, David Williams, president of Health Business Group. I conduct in-depth interviews with leaders in healthcare business and policy. If you like what you hear, go ahead and subscribe on your favorite service. While you're at it, go ahead and subscribe on your second and third favorite services as well. There's more good stuff to come, and you won't want to miss an episode. If your organization is seeking strategy consulting services in healthcare, check out our website, healthbusinessgroup.com.